Okay, hello everyone. Welcome to our webinar tonight, which is From Diagnostics to Access to Restoration. This is the second part of a webinar that we began last week, and hopefully some of you saw what happened last week. I'm sure a lot of you this is new. And the nice thing about today's webinar is that we are going to go over some of the things we mentioned last week. In fact, the first 5 slides are pretty much the same as what we went over, but obviously from there on 95% of the presentation is new. My name is Joseph Chikvashvili. I graduated from Maryland Dental School and I did my endodontic training at BU in Boston. And as you can see, I'm Director of Endodontics at Newark Beth Israel, GPR, where we teach 12 residents. And I'm also the president of the New Jersey Association of Endodontists. Again, I welcome you guys, and we'll have questions at the end. And hopefully, really why I do this webinar is I want a lot of you guys to learn to do better access and better diagnostics. Last time we spent a great amount of time on diagnostics. Today we're going to do a lot more on access, although we are going to still mention diagnostics as well because the two go hand in hand. Okay, so these are the objectives as they were last time, and the real issues that I want all of you guys to get better. I always tell the residents there are 2 things that I want. One is for everyone to get better and improve so that it was worth the while, and the second is for everyone to know their limitations. So hopefully today we will help you out. This is a slide that I always show, and I went over this. Like I said, these first only 5 slides are the same. After that we go into new material, but I always show it because this is really a great example of why you need more than just a PA. This is a patient that has pain to hot and cold, and really every tooth looks like it could be a culprit. I mean, you have large restorations, you have a crown, and so forth. So if you look at the PA on the left, it doesn't look so great, but the PA on the right does. And most people guess, well, it's either tooth number 3 or tooth number 4. But, the question is, which one is it? And when you look at this, you can't really be certain. And obviously, you still can't be certain without doing testing. However, look at the difference when you take a bite wing. And what I mentioned last time is I look at this bite wing and read it very differently than most people. I don't just look at it and say, oh, it's number 3, there's gross decay, fantastic. I look at it and I say, look what's going on here. You have a periodontal defect around tooth number 2, you have decay on 2, you have decay on 3, you have multiple restorations, you have a tooth with multiple restoration types, number 30. You have canals that are calcified and chambers that are calcified. You have group function likely because look at the flat plane of occlusion here. And you have a post that was put in probably needlessly on number 31. I mean, if you need a post, I shouldn't say needlessly, it probably needs it because you can see there's missing tooth structure. But that post is not doing its job. It's too short of a post. So you're putting too great a fulcrum on that tooth. So there's been a lot of dentistry with this person, and you gain a tremendous amount of knowledge by looking at this bite wing that you do not gain when you go back and look at the PA. So this looks just like, I don't know, everything looks pretty good. And here you're like, oh, it's not so good. You got group function, you got periodontal disease, you have caries, you got all kinds of things going on. So the short version here of why I bring this up every time is you really have to take bite wings. Okay? So this is a slide also that I show all the time, which is when you look at the tooth from the left, it looks fantastic. And this is the same tooth on the right, just turned 90 degrees. So the message here is when we look at teeth, we're looking at this view here. And people often say, well, I don't understand. How could that be, bothering them, Dr. Chick? Well, remember, we don't do things in 2D. Everything is 3D. So you have to think in 3 dimensions. And what you realize is something that looks so good like this in this dimension is terrible. This is 20% obturated, and it's not 20% clean. It's 100% dirty. Obviously, if this is the way it is, and this is all dirty bacteria here, this is also dirty with bacteria. So it doesn't matter that it looks good. It's really terrible. And so this is, if nothing else, I always tell students, I said, you have to remember this slide. And people say, well, but do you ever see that in real life? And again, I showed you a case where we do see that in real life. This is the same PA, 2 different views, and the view on the left looks like, everything is fantastic. And the view on the right, you can see that it really is not fantastic. This is essentially someone who perforated a tooth and thought they were doing a great job and thought this is what they were doing, when in reality, this is what they were doing. So believe me when I say you need to have a good concept of what you're looking at in 3D. And sometimes even an off angle is better than a good angle, but in this case it's reversed because you can see the off angle things look good, and the proper PA, where it's not elongated, you can see what's really going on. But the problem is if you look at this, you think, oh my gosh, this is great, what's the problem? And when you look at this, you say, okay, it's a little bit of a different story. Okay? So some of the important points that we mentioned with regards to diagnosis is that obviously you can see how PAs can trick you, okay? So you do need multiple views. Now, I know people say, oh, I don't want to take x-rays, but listen, if you can't see what you're doing, how are you going to help someone out? So you either have to have a patient understand that you're going to come to grips with, yes, you have to take certain amounts of radiation, which are very minimal these days, but yeah, all radiation is cumulative, so we don't want to take it for nothing, but if there's value in what you're doing, you should take it. Okay, and that means take a bite wing whenever possible. Also, we mentioned look at everything because even though we're endodontists, some of us, we look at things apically. You also have to look at coronally. I showed a case last time where the problem was decay in the furcation, and so it looked like there was an area, but the problem was really contamination. Off-angle PAs are very helpful. Looking at adjacent teeth, if you have 3 canals on tooth number 5, there's a decent chance that tooth number 4 is going to have 2 or 3 canals, and definitely not 1. So you should know that, okay? And the last thing was a case that I showed where someone had prepped a tooth thinking I would do the root canal, but ultimately I couldn't do the root canal because the tooth was not savable, had a resorptive defect. So try not to prep teeth and then do root canals. Now, obviously, that's not always doable. But if you know that a tooth is necrotic, let the endodontist or the general dentist do the root canal first, and then go ahead and go back to making the crown. So as far as diagnosis, we mentioned we use a lot of different tools. I don't use all of these on every single case, but I will, obviously, radiographs I use in every case. I do endo-ice generally on every case. Percussion I always do because it's simple, easy, palpation. Mobility I do on a lot, and probing I even do on a lot. You'd be surprised how many times you find large defects that you didn't even know existed, and all of a sudden you might realize that, hey, maybe this tooth is cracked, and I didn't even realize that. Fiber optics and staining with dyes is also something that is often overlooked. I mentioned the 2 things that I use for staining with dyes are generally to dye for or methylene blue. They're both excellent. To dye for is a little bit less messy than methylene blue and easier to use because they're in these little individual packets, and that's why I like to use that a little bit more. But they're both great, and they have different purposes, okay? Meaning this also can stain for decay better than this will do. But this I use sometimes for surgery when I want to see where that canal really is, okay? So going back to our diagnosis, which we talked about last time, these were some of the tips we said. We always test a good tooth first, and the reason for that is you want to make friends with the patient. Especially endodontists, we don't see people more than a couple times. So you don't want your first experience to be endo-ice on an irreversibly inflamed tooth. That's not good for making friends, and it's not really nice to do to the patient. But really the more important issue is that you need to know what the baseline is. And some people are very sensitive to cold, some are less sensitive to cold. So how do you know if you haven't tested baseline? So you should always do a tooth that you think is normal first. Now I know other people say things differently, but I think I gave you a couple reasons why I disagree with that, and it's better to always do a good tooth first, okay? We don't diagnose just looking at a PA. Obviously you can have all kinds of PCD and different things that mimic radiolucency, okay? Osseous dysplasia and things like that. So make sure you test it and see if the tooth is vital or not. Because if you test it and it's vital and you have a radiolucency, you know that it is not an endodontic problem, okay? For molars, and this is really very important because I see this all the time. In fact, I had 2 cases today where I have to take maxillary and mandibular PAs because the patient thinks it's the upper, but they're not sure. And a lot of times we know we get referred pain, vice versa. Number 2 can be number 31, and number 18 can really be number 15. So just because the dentist sends you a PA of tooth number 15 doesn't mean it's number 15, unless the patient says, oh, I'm positive, and you test it and it's acute, and it's percussion positive, and it tests like that to endo-ice. That's a different story. But if you're not sure, taking 1 extra PA can be very helpful. And it's really important because if you don't treat the acute pain first, you're going to make a person more miserable. So you have to make sure you treat what's hurting them. You know, I mentioned a case where the patient had a radiolucency on number 30, but 29 was what was hurting them. So if you open 30, yeah, 30 needs a root canal, but you're going to make them hurt more because 29 is what's killing them. Okay? And for that reason, you got to document your preoperative diagnosis and your post-op diagnosis because sometimes they'll be different. I went into a tooth today that I thought was going to be completely necrotic, and two of the canals were necrotic, but the distal was actually irreversibly inflamed. So we need to know that, and it makes sense why the person was having pain because the tooth was half dead and on its way to being totally dead. UPOD is an acronym for under promise, over deliver. So always kind of prepare for the worst and think about the worst case scenario, but try to do the best that you can and overachieve for your patients, okay? This is true for everything in life. And you have to listen to the patient. So if they're telling you that their pain is to hot and cold, that's going to be the test that you want to do. And if it's hot, maybe you have to do hot. Maybe endo ice won't give you the test that you want. But doing hot is a little bit more challenging. When I do cold, I do endo ice. When I do hot, what I do is put a rubber dam on the tooth, and I try to put it as high as possible so it doesn't touch the gingiva. And then I take nuked water that I put in the microwave, put it in a syringe, and then I bathe it on the tooth. And usually I get the result. But obviously that's a lot harder work than doing endo ice. I'll also mention with endo ice, I said that you have to use a loose cotton ball. You cannot use a cotton tip applicator or a Q-tip because the wood transfers some of that cold and you don't get as good a result. And you can't use a tightly wound cotton ball because that also doesn't transfer the cold well. So you need a loose cotton ball, cotton pellet, and that is what you do the endo ice with, okay? So use whatever test you think are prudent. Now I'm going to go into access because that's really what most of tonight is about. And like I said, we started this last time. Access is one of the first things you do, obviously, after anesthesia diagnosis. But it's one of the last things that people get good at doing. And it's tricky. The reason it's tricky is because a lot is riding on it. If you're working on the lower anterior, you don't have a lot of leeway to make a mistake as opposed to if you're working on a maxillary molar. So the goals for access are to preserve as much tooth as possible and to not try to destroy the crown, but to also open things wide enough to facilitate, thorough cleaning and debridement. Okay? Now, in the last few years, there's been a big move to people who do kind of like ninja accesses, just, to show how tight they can make things and how impressive I think they are. Whether that makes a difference in the outcome of teeth, I don't know. We don't have those studies yet. But I will tell you that, yes, you want to make it as small as possible, but within reason. And if I'm going to err, I'll err generally on a little bit of a bigger access just because, we have unbelievable restorative materials in 2018. And the truth is that if you don't open things wide enough, you're going to have other problems, okay? Now, when I say I open things bigger than I need to, this is actually a typical molar access that I do, okay? Maybe even a little bit smaller, I'd say, than my typical, believe it or not. I make it a little bit bigger here. But you can see this tooth, which I got 4 canals through a zirconium crown, look how really minute this access is. And it's because I could get into 2 canals here and 2 canals here by just tilting things and still have relatively straight line access. Now, what I'm saying is if you have to open this a little bigger and go like this, hopefully you can see my cursor, that's fine. Just stay away from the marginal ridges. Try to stay as much as you can centered. This tooth's going to be in great shape. It might not be as great as what I did, but you don't always have to do that, and ultimately it's still better, okay? So these are the kind of accesses that ultimately you want to do. They're a little bit bigger than what I just showed you, but this tooth had 3 canals, this tooth had 4. You can see there's a rest seat for the partial, so what did I do? I did my best to stay away from the rest seat. I did my best to stay away from the oblique ridge. And I think the interesting point here you can see is that I stayed away pretty far from the palatal, despite being able to easily clean out the palatal canal. Look how buccal this is. Same thing here. So when you start doing enough of these teeth, I think you will see that, hey, you know what? You don't have to go as far this way as you thought. And you don't want to be as close to the marginal ridges as you need, okay? So that tooth, I imagined, hey, this is what I want, okay? This is the kind of access. And sometimes my real access is going to be bigger than this. And in this case, you can see it was probably even smaller, Okay? But the point is, you have to imagine what the finished result is. And the only way you can imagine this is to look at the PA and say, hey, where is the pulp horn here? Where am I going? What does this tooth look like? Does it have 2 canals, 4 canals, 5 canals? You know, whatever it is. And a lot of times I don't know. I go in and I say, this looks like 3, so I have to assume it might have 4. This looks like 4. I have to assume it has 4 and maybe even 5. I have about 40 teeth with 5 canals that I've treated in the last, you know, I would say about 7 years. So believe me, they're there. And it's not that they weren't there in the 1960s. How come all molars had 3 canals? It's because we didn't have microscopes and magnification and the knowledge of cone beam that tells us what is really going on here. Okay? So with regards to access, we mentioned that the first thing we do is reduce occlusion. Now this is, people say, okay, yeah, I'll do it. There's a big difference between doing occlusion in the beginning and doing it at the end. And I mentioned that it's important to do it in the beginning. Number one, you want to make sure that you reduce it so that you have less post-operative pain. I know there are people that are going to say, well, you know, you don't have to reduce occlusion. I would tell you absolutely that is wrong. For some people, you do not have to do it. But for other people, if you don't reduce that occlusion, you will be in trouble. Now, if the tooth is getting a crown, we don't worry about it so much. If they already have a crown, I generally try not to reduce it too much, with the exception of the tooth is very acute. So if the tooth is extremely acute, I will soften it, because otherwise I will be getting a call at night and the patient will not be happy and I'm not happy. But one of the issues is, the reason we do it before the procedure is for really 2 reasons. One, you get an accurate working length. If you take your working length and record it in the chart and then you reduce occlusion, now your working length has changed. So you're not going to be as accurate as what you did before. But also, the patient's bite is going to be much more accurate when you start the procedure as opposed to when you're done. I will often even go and reduce the occlusion before I've even numbed them a little bit, just so that I know that I have properly reduced the occlusion. Because after their mouth has been open for half hour, or sometimes 2 hours, when I see people in our dental clinic at the hospital, you know, these people, when they close their mouth, they're not biting the way they were when they came in. So you might think you reduced the occlusion, and then tomorrow they call you and say, hey, I'm still hitting that tooth and it's hurting. And you're like, well, I don't understand why that is. So the best thing to do is do it basically before you start. Okay, so obviously imagine where your best chance is to find the canal. Look for those pulp horns if they're there. Start small and go wider. Always try to go as small as you can, but there are times where you will make an exception to this, and that is maybe if something is really calcified and the access is challenging, you might even have to open more than what you want to, just because you know that it's going to be tough to really gain your bearings, okay? But like I said, stay away from the marginal ridges, and then you're going to have less problems with breakage, particularly with crowns, okay? If you're going to use air water, which I use a lot, you know, use it for a couple things. One is to clean the surface. After you do that occlusal reduction, you get a lot of debris, a lot of schmutz. So you got to really clean that up, okay? But don't aim it down a canal, because then you get a risk for an air embolism. So I always blurt out a little bit, bust out a little air, but it goes to the sides, and I actually do it a little bit away from the tooth, so it's not, I never do it putting the tip completely in the chamber, because I don't want that air embolism risk, okay? Again, where you think is the best chance of finding the canal is where you want to go. Now, in the old days, this is what they teach you. They say, okay, you got an anterior tooth, you come in from here, you go like this, and I'm going to tell you when I did it this way, and even now when I do it, because I have to do it this way sometimes, I go like this, and sometimes you can really go like this and gouge out that tooth structure, and especially if you use a round burr. Now, in this case, you can see we have a really decent pulp chamber. The teeth that I see are never like that. But maybe some of you are luckier and you got more normal practices and patients than what I get. You know, I get very challenging teeth. So, you know, then they say go in and clean it out. And the problem is that once you've done this, and you've gone out and you've cleaned this out, what you've really done is, yes, you've gotten sort of straight line access, but you've also obliterated the cingulum. And the cingulum is really what keeps things together for anterior teeth. So the same way you have to keep the oblique ridge and marginal ridges for posterior teeth to keep them in shape, you have to keep the cingulum in shape. Otherwise, this tooth is weakened, and now it's more susceptible to fracture. And a lot of times we don't put crowns on these teeth, and then they break. So you don't want to do this kind of an access, ideally, if you don't have to. And if you do have to, you definitely don't want to go this far down, because even though this is a non-cutting tip, you can still cause problems even with a non-end cutting tip. So if you have a tooth like this, okay, you know, what do we what do we normally think? We think, hey, you got to go in this way, right? But I like to think, what about this way? The advantage here is when you come from here, yeah, no one sees it, but no one's really going to see this either if you pick a decent shade. And where's this person wearing things down? Occlusally. You can see where, everywhere here there's occlusal wear. So what's more straight line? This. You can make a tiny, literally 1 to 1.5 millimeter hole and boop, find the canal. As opposed to here, where you're going in from the back, you got a curve, then the canal itself may curve, and now you're knocking out whatever cingulum is left. So think a little bit out of the box and say, hey, maybe this is a better way to go, especially since I might want to build this up and restore it anyway and fix this guy's occlusion a little bit, okay? So it brings us to the next point, which is, do we need straight line access or a glide path? And I think the short answer to that question is definitely yes. Just like this plane needs this to land. I mean, I'm sure they can see without it. It's a beautiful day. But look how much easier it is when someone says, hey, buddy, it's right here. So the same thing in dentistry. Now, that doesn't mean you have to open things tremendously. Okay, but when you're starting teeth and you haven't done a lot of molars, this may be what you have to do. And eventually this will get smaller and smaller and smaller. And one of the issues here is, and this is an old tooth, I did this, I don't know, maybe 15 years ago, but you can see everything. Normally on the teeth that I do now, my axis is probably, I don't know, I'd say half of this. And I can't see them all by holding a mirror like this. I literally have to turn the mirror every which direction to see every canal. But I like this because you can see the distal, the MB, MB2, palatal. And one of the interesting things is here I open MB and MB2 pretty much the same. And generally I would say you don't want to do that because MB2 is smaller than MB. And it's not only smaller, but when you look at it in cross-section on a cone beam, you'll see, so it's like a pear. You have the bottom of the pear here and the top here. So you shouldn't open this too much, otherwise you start to weaken that tooth structure and you can sometimes strip perf. I think you'll get away with it a lot, but you know, you also will get caught. So what do we do when we have a tooth like this that looks like, oh my God, this is a rhinoceros tooth, I don't know what's going on here. But it's also the abutment of a 3-unit bridge here, so there's a lot of value in this tooth. And if you lose it, you got problems. You can say, well, look, let's just put an implant. Okay, well, you need an implant here, you need an implant here. I mean, it's $10,000 where I am to do 2 implants like this, and you got a roller coaster for bone. So what's the likelihood that we're going to get some great aesthetics here? You say, well, it's in the back, who cares? Well, when you get a food trap and then you get a root canal on this tooth down the road, everything matters. So the point is, I look at this and I say, you know, how am I going to approach it? So what I approach it is like this, and I don't know why all these lines came at the same time, I'm sorry, but essentially you can see the inner lines here is really all I have to do to get to you know, where I need to be, because I can come in like this, I can come in like this, but the outer lines also start to incorporate these pulp horns. So while ideally I maybe only need to open it to these inner lines, the outer lines is more practical because now I've really encompassed everything. And have I really opened things too much? I don't think so. I think this is a really nice access here. I haven't taken away more tooth structure than I need, and I have all the canals cleaned out to length very nicely. And by the way, some of these bends are really ridiculous bends. These are actually not too bad, but the 2 distal bends are really difficult. This is a radix entomolaris, a tooth that has 2 distal roots. And this is, you know, these are very difficult teeth. Here you can kind of see and appreciate the bend. This one you can't. This bend is actually the worst bend out of the 4 of them. Okay? And you see this large radiolucency that's here. It probed greater than 10 millimeters. And now probes 5 millimeters and the radiolucency is essentially gone. So, you know, it shows me that we're winning. And she keeps her tooth, she keeps her bridge, and now she doesn't spend $11,000 on, you know, 2 implants and bone grafts and everything. And literally it's just the cost of doing the root canal. So even though a molar root canal is expensive, it's a molar root canal, restoration, and we're done. And it's a lot simpler, 2 visits. So ideally, you want to say, look, here we have this beautiful chamber. I want to go right here in the middle, clean out these 2 canals. And when you look at it, you see this. Now, is this what I normally do? No, this is an old access of mine. And like I said, I probably make it thinner and smaller. I can actually make this less oval, almost circular, and still get into both of these canals. But there's nothing wrong with this access. This is a great access. You go in, You see both canals. You've cleaned everything out. Tooth is in fantastic shape. And this is ideally what you want to do. And if you can't do ideal because you have decay, all right, you don't have such a perfect access, it's not the end of the world. You can see the two canals here. Is this a tremendous amount of tooth structure that's lost? In 2018, this is easily restorable with composites. Okay? The problem is that if you don't do it and you try to make things small or ideal, sometimes you miss things. And here's one where I didn't even go so small. I just did a routine access because there was decay, and actually even maybe a little bigger. And I did all the canals here, 3 canals, what I thought. And all of a sudden the patient comes back 4 years later with a palatal swelling. And when I look at it, I say, I don't know. I mean, it looks like a nice crown. Everything's great. I see there's a little bit here of an issue, but it's definitely this tooth that's hurting him, not this, even though this doesn't look great. And I say, hey, maybe you need a crown on this tooth. I look at this. This looks good. This good. Obviously, this is 20 years ago, so I was heavily using gates, which I don't even hardly use anymore because I just open with rotary. I really try to preserve as much coronal tooth structure. And the only thing I see is maybe there's something going on here in the palatal, darkness. So I wonder, what could it be? And ultimately, I wanted to retreat it, but the patient didn't want to do it. They said, look, I think I'd rather just take it out because of finances. I don't want to go back, even though I would give them a significant discount. I think it was about 4 or 5 years later. And so ultimately, we pulled the tooth. And here's what we found. We have essentially a second palatal canal. I don't even know if I want to call it a second palatal canal as much as I would say that it's just an enormous palatal canal. I mean, look at how big this is. This is the gutta percha, by the way, from my palatal canal. So that's what I obturated. And this little dot here and this dot here is the 10 hand file. So let's go back here for a minute. And so you can see we have a canal here, here. This is the palatal right here, which looks great on radiograph, and it looked great, even looks great here, right? I mean, maybe a hair out here. What you realize is it really is a hair out. And so what looked good on the radiograph previously here, right, that looks good, was actually long. And this is actually like a 400. Now we have things like gentle wave, for example, that will help us to clean this out better. But whether that actually makes it better or not is, still remains to be seen. I'm waiting for long-term studies, which we obviously don't have yet. It's a new product to the market. And this tooth ultimately was lost. Also, you see there were some cracks here, and I think that's also what bothered him. But unfortunately, what I'm trying to show you guys here, and you'll see it better here, is that you can't win on every tooth. I mean, look at this enormous palatal root. This is a 400 or a 500. And we do not have files at a 400 and 500. So yeah, you can use gentle wave and you can go and just irrigate and you can use ultrasonics, but ultimately you're not going to do a good job here and you may lose. And that is also something that's important to realize, that while I'm giving you great tips, these tips work for 95% of teeth. They don't work for every single tooth because you're always going to get anomalies. Okay? But let's talk about the normal tooth. What do we use? Usually I'll use a football, sometimes I'll use a stray diamond, but generally I use a football to knock down the occlusion, okay? For those of you starting out on a PFM, you may want to use a round diamond. I don't use it because they're too big. You're going to make bigger accesses than what I do. But I think it is good when you start out to do that and to use that with copious amounts of water, staying away from the marginal ridges, and you will go through the porcelain. Then you can use, this is a SS White number 2 burr, which is great at cutting the metal. Okay, but I generally use chamfer burrs, and I use a thin one and a medium one. Depending, like if it's a lower anterior, I might use a thin one. Sometimes I use a medium. It's a little counterintuitive. Sometimes you think, well, you got a small tooth, you should definitely use a little one. But the problem is that sometimes using the thinner one will actually cause you to overheat it and break the porcelain more than if you had made it a little bit wider than what you want it to do. So you have to just really practice, and you'll learn and figure that out. But the point I'm making is you're going to make a much smaller access with this than with this. So ultimately you have to get to where you can do it like this. And when I use zirconium, I use this as well for the zirconium crowns, but I also sometimes use burrs from Brasseler because they do have special burrs for cutting through zirconium that are even better than this. The problem is they're, I think, 2 or 3 times the cost. So I don't always use it. Sometimes I'll just go through 2 or 3 of these burrs instead because sometimes I can get through with just one or two of these burrs. But it is nice to know that there are companies that do that. Okay? So if you don't have a crown, I generally will use a 557. Sometimes I use this as a 169L. This is for those anteriors where I make literally a 1 millimeter hole. You know, sometimes I'll go in with ultrasonic and widen it as well, because especially if I have to bleach, like today I had a tooth that I had to bleach where my initial access was maybe a millimeter, but I almost opened to 2 millimeters because I couldn't get the bleach in otherwise. And sometimes you have to do that, and you really want to make sure you clean out those pulp horns, because for anterior teeth, you can stain teeth and stain crowns. Okay, so you have to make sure that you remove as much debris as possible. Again, for if you're trying to look and see if you cleaned everything out, this is one of the things I use to die for. One of the questions I get a lot is, what files do you use? And I really think, you know, K-files are what works great for me. Some people like reamers. I think it's a preference. I think they're both, once you get good at filing, it really doesn't matter which one you use, but I find the K-files to be better. I don't usually buy these packs. I just get a pack of 15s or 20s or whatever, and on my sponge I'll have 6, 8, 10 all the way up. I'll have a lot of 6s, a lot of 8s, a lot of 10s. People say, 6s, really? I go, yeah, the teeth I get, I mean, it's rough. But my favorite file is the C file, and I actually think this is the best hand file on the market. Now I will show you why, you know, you need different files for different things in a minute, but this comes in 6, 8, 10, and now even 15. And the reason this is fantastic is this is a little bit of a stiffer file, so you're less likely to have separation, you're better at getting through the calcifications, and I got to be honest, these files are amazing, and I still think they are very flexible. You say, well, what do you mean? Are they flexible? I mean, how does this look? I think this is incredibly flexible. You can see a 180-degree bend here that was eventually obturated. Again, you can see same tooth, just different views. So we did 180-degree bends, and this is from, I think, 8 years ago, a tooth that I did, but this is from a month ago that I did. And look at the bend. This is someone else's root canal that they did here. And this person came in, and I treated this, had a bad bend. They all are bad bends. The palatal, distal, mesial. This was 24 millimeters, 25, 25, 25. Look at the bends here. This ends here on the mesial, okay? So that's MB, MB2 goes to here. I mean, this is just brutal, and that's the kind of things that unfortunately I get. So these, you know, files that I show you can get around these bends, and that's really, really fantastic. However, there are times when you want a stiffer file, and this file by Dentsply, the C+ file, is good for cases where maybe you have a retreatment, you want to get some gutta percha out, and this file is so stiff that it's a little better at getting you know, that debris out without separation. So there are times where I want this. You know, it's kind of like, do you want flexibility or you want strength? You can't get both in life. If you have a flexible file, it won't cut. If you have a file that cuts great, you're not going to have flexibility. But there are advantages and disadvantages to each. So when you're doing a retreatment and you're starting and you're going through that gutta percha, you want a stiffer file. But for 95% of the files, you know, teeth that I use, and you know, see, I use these C files or the regular K files, but mainly the C's on the lower sizes, so 6, 8, 10, and even sometimes 15. Okay, so ideally you want to always open a tooth to a 15 or a 20 hand file before you go in with rotary, and what you want to do is try to get that straight line access. And I think a lot of you guys will go like this and slowly make your way down further, 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 all the way to the end. And that's what we call crown down. I'm sure a lot of you guys are familiar with that. And they teach that because they say it's a lot faster to get down a tooth because you get less blockage up here and you can clean this out better. Whether you do step back or crown down is a matter of preference, okay? I can tell you that while a lot of my colleagues do it this way, crown down, I actually go reverse and I do step back and I go all the way here and reverse. And the reason I do that is, you know, the tooth that I showed you just now with those ridiculous, ridiculous bends, I like to do that and do hand filing with a 6, with an 8, with a 10. And if I lose that canal and I just start opening things up coronally and I can't get back in there, I may never be able to get back in there again. So for me, I can't lose it. So I have to get down all the way to the end before I start backing it up. Now that doesn't mean I don't obviously I couldn't get a 6 file all the way to the end on that tooth with a ridiculous curve. So I went as far as I could. Then I did use rotary to open it a little bit, go a little further with the 6, rotary again, a little further with the 6, and eventually I worked my way down there. So I was doing crown down. But once I got the 6 to length, then I really did step back because I did not want to lose that. I wanted to be able to get to the end. Okay? But again, this is a matter of preference. The main points that I'm trying to make are for access, you want to do as much as you can to preserve the tooth, okay? But the advantages to a small access, as you can see, are very few. In fact, there's a ton of disadvantages. It's harder to see, tougher to clean, you need a lot more PAs. If you can't fit all 4 cones in, you might miss a canal because you didn't open it enough. You have less straight lines, so you might separate an instrument. So initially, I want you to open things a little bit bigger. I'm not saying gigantic, but you really need to be able to learn anatomy. And it's important because of the way our brain thinks. Now you say, what do you mean by that? Well, I'm going to get into that in a second here. In fact, right after this slide. Okay, so one of the important tips that a lot of people don't tell you is sometimes, and I do this, I will start the access without even the rubber dam. I do this for 2 reasons. One is you want to make sure you get the right tooth. I mean, if you're working on number 24, 23, 24, 25, 26 can all look exactly alike. So it's a lot easier to just start it before you go, before you put the rubber dam to make sure that you got the right tooth. Now you can mark it with a marker or whatever, but now I'm introducing again schmutz that's going into the tooth. So I prefer to just do it. With the exception of if it's a vital tooth, I may not make the complete access. I might just make a little divot because I don't want to contaminate the access that I'm about to make. So in that case, I'll just make a little divot and then I'll put the rubber dam on and do the whole access. But the other reason is you get your bearings, and sometimes the tooth is rotated and it's hard to really see which way you need to go. So sometimes I will make that access and then I'll put the rubber dam, or I'll take the porcelain off with that straight diamond, then I'll put the rubber dam, and now I go through the metal, and that's why I can make these small accesses, okay? For those of you who say, well, how do I get better? The answer to everything in life is practice. And I'm going to be honest with you, I still do extracted teeth because I still like to practice techniques. So you can never do enough here. So please, by all means, practice, practice, practice. Well, one of the things I want to teach you is, the way our minds work is also very interesting. If I give you this next slide, these are 12 letters, and I say, I want you to memorize this, F, X, G, B, Z, I, D, F, L, V, Q. And I say to you, okay, can you repeat that to me? Everybody's going to say, oh my God, I don't know what he just said. F, X, and then I forgot it, okay? And the reason for that is the way our brain thinks. Let me show you the difference. FBI, KGB, CIA, NFL. FBI, KGB, CIA, NFL. How did I remember those? Well, it's not that I'm such a genius. It's that our brain likes to compartmentalize things. And so what we do is when I gave you those 12 random letters, you said, oh my God, it's too much. They're all random. I can't do it. But when I gave you 12 letters where it was 4 groups of 3s that you're familiar with, CIA, NFL, KGB, all of those, it's much easier for you to remember what's going on. And the reason that's important is because your brain will trick you with radiographs, it will trick you with access. I showed you how it tricks you with radiographs in the beginning. The way it tricks you with access is you have to see 1,000,000 of the same access before you will know what to do for 1,000,001. And by that I mean if you have a C-shaped canal, for example, which is very unusual, but it happens about 1% of the time, a little bit higher in the Asian population, 2.5% of the time, it's going to be challenging for you to get that anatomy. But the more you do, the better you're going to get. And the only way you can get your brain to pick up on these patterns is to do as much as you can. If you know the floor plan for 1,000 Victorian homes, I can put you in a Victorian home and you're going to know exactly where to go, even though you haven't been in that home. It's the same way with teeth, okay? So, again, what do you have to do? You have to use a lot of water to not break crowns. You have to remember that usually the canal is going to be more lingual than you think, particularly for anterior teeth, like maxillary anteriors, okay? But also mandibular. A lot of times we go very buccal and we miss that lingual canal. Those lower anteriors have 2 canals 44% of the time, okay? Maxillary Second molars, generally that anatomy is going to be more mesial than you think, so you really don't have to go off the page and go really distal. You have to wonder sometimes, is it worth finding MB2? 80 to 85% of the time, they join. And that's why we get away with not finding MB2 and having a problem 5, 10, 20 years. Obviously, we want to find it whenever we can. But there's also the famous line by Voltaire, which is, the enemy of good is perfect. So sometimes it's better to do a 90 and not a 100, because if you try to take a 90 and convert it to a 100, you might fail. So these are things to keep in the back of your head. And to do all this, I'm talking about using magnification, obviously. Now, I use a microscope, but I know a lot of people use loupes. Microscope is better. There's no question. Even microscope is not enough sometimes. Loupes with headgear and light is also better. And if you're doing molars, you really have to, at the very least, use loupes. But as you get better, if you make your way to learning to use a microscope, I think it will help you immensely. Okay? So even this is the kind of access that I think you guys can do where you still find 4 canals through something like this. That's generally, I would say, more symbolic of what a typical access is for me. I can make it less than this, I can make it bigger, whatever I need, but just where you see a little bit, and if you turn the mirror, you will be able to see all those canals better. This is a tooth that was, literally 20 years ago. One of the residents was troughing here, and I show it just because it's really a good picture. You can see you have this, distal palatal here, and they were looking for MB2. And I think a lot of people just trough like this, but usually when you have this triangular pattern like this, and you got nothing going on here, this probably only has 3 canals. And normally MB2, you're going to want to go more in this direction. And the reason you don't get it is because this little bit of dentin can sometimes really mess you up, because it's like a lip that hangs over and you have to remove it. So you'd be better off going a little bit like this rather than the direction that they went over here. Okay. Similarly, sometimes MB2 can literally start off here, and you're like, what is going on? It's so close to the palatal, but by the time you open it, it comes to somewhere around here. And then you say, okay, it's kind of halfway to here and halfway to here. So this is where you have to just practice and do enough cases where you ultimately will see. And what you should find is generally MB2 to be further mesial, further palatal to where MB is. And again, this is a really old case from about 15 years ago, because I found one which was big enough where I can kind of show you everything. All right, so you don't need to open it this big anymore to do it, but I think when you start, you will have to. It's not the end of the world, but obviously the less tooth structure that you can get rid of, the better. To remove less, I do it under magnification and a ultrasonic. I use both ultrasonics here, Tulsa, Kerr. They're both excellent, and I use different tips. Usually I use a tip like a buck 1, buck 2, buck 3, and it's like these tips right here, Buchanan. These are more for retrieving files. This is also sometimes good. You can also trough with slow speed round, but obviously it's a little bit tougher because you can't see everything you're doing. No matter what you do, you're going to need a little bit of luck. I don't care how great you are. I always tell my patients, without luck, we are in trouble. So when we do a retreatment, we don't tell people, oh, I'm just going to retreat your tooth. We always say, we will attempt to retreat your tooth, because we want them to understand that while we will do everything we can to get down there, you don't know what's in there. And you may not be able to get the gutta percha out every time. Okay. Restoration, I'm not going to talk about in great depth, because really most of this I want it to be endodontic and about access and diagnosis. And we're going to finish with, I think, 3 cases on diagnosis right now. But the point here is, I use etch, I use bond, composite. I usually will do flowable, then I use a core. The flowable is nice because it really seals the floor, and the core is because I want something durable. Some people will use a flowable that's different colors so that it makes it easier if you end up later on going to retreat it. That's fine if you're doing a molar, but if you're doing anterior teeth, obviously that's not great. One of the questions I always get is, hey, do you need to do crown if you're making this kind of an access on this 3-rooted premolar? And the short answer is yes. Until I see that, we have studies that say you don't need it, posterior teeth should always be crowned. There are some exceptions. There are people where, for example, this tooth may not really be in such occlusion with what's going on, or because of finances they don't want to do it, fine. But ideally, you still have to recommend to them, in my opinion, to do a crown, even on something as tiny as this. Okay? Now I'm going to do the final 3 cases, and I'm going to go back to diagnosis just because I want you to see some things out of the box. This was a case where a lady was getting 3 ceramic crowns. She fell the day of insertion, and she said to her dentist, I don't know if I can get my crowns today. I really hurt myself. So I take a PA, and I see there's a radiolucence here. And it's not here, apical. So what's going on? You can see there's actually 2 cracks here on the cone beam and 2 crack lines here. So this tooth is broken. And I think most people would say, well, you got a radiolucency here, you got 4 cracks and maybe more cracks down here, just take it out. But when I look at this as an endodontist, I said, well, let me think a little out of the box. We got these crowns, they're ready to go. The lab bill is paid, the patient's paid. Maybe we can do something different. And what I did out of the box is I did a conventional root canal. And I wanted to see if the calcium hydroxide went into here, because I knew if it went into here and it followed this, it would get in there, and I would treat this like what? Like a lateral canal. So ultimately I did that. I finished the root canal. You can see the lateral from the fracture. And interestingly, only 1 really filled in, but that doesn't mean that sealer isn't there. And you can see at the 5-month post-op, look at the beautiful healing that we got here. So yes, small access, nice composite. I got a little void here, and I left that in here just to show you I'm not perfect. Sometimes you get air bubbles, by the way, where you will not get perfect, but you always try to do as perfect as possible, okay? And in a closed system, sometimes that will happen. But the issue is, I saved this lady her teeth, and she ultimately was able to get her crowns. And I have to include it now because I have 4-year post-ops on this, so that's really fantastic. And I'm sure almost everybody here would have said, well, just take out that tooth. Here's a better one. This was a girl who, again, had a small radiolucency, and then the endodontist did a huge access, really took everything apart here, did 4 canals. Yeah, great, but look at how huge this access is. And then a year later, the oral surgeon says to me, look, Dr. Chick, this is not healing. I mean, this is a huge 1.5-inch radiolucency now. All right, we don't call it a lesion until you biopsy it. So you can see the sinus is obliterated. Unlike this is normal sinus. This is pathology here. And he says, I don't know what to do because she's having pain here. I don't know. Do you want to do the root canal first? Should I take out this tooth? Should I take this out? What do you think we should do? So I say to him, I said, well, look, I'll do the root canal, and that's the tooth that I just showed you a little while ago when we were talking about it. And you can see the difference in technique between the guy that did this root canal and the root canal that I did here. I did also a fantastic root canal, but look at what I took away as opposed to what he did. And I know somebody will say, well, there's a lot of restoration and so forth, but this is really, in my opinion, a little egregious. I said to the surgeon, I don't like to take out this tooth unless I know what's going on here. Why don't we biopsy it and see what it is? Maybe it's a cyst. Who knows what's going on? So he said, I'll tell you what, I'll go in, and I think he went in through the sinus and enucleated everything here, and it took a biopsy. When I said 6 months later, how is she healing? He said, you know what? Believe it or not, this might be healing a little bit, so I don't know that I'm going to take out this tooth. Let's wait. And it came back, by the way, as dentigerous cyst. So obviously it's a cyst associated, sorry, not dentigerous, radicular cyst, a cyst associated with a tooth. So obviously it was coming from this tooth. So it just meant that the root canal was likely failing. But watch this. This is 2 years later. Those PAs, this is when she was 15. Now she's 17, and she drove to my office. And look at the amazing healing here. The 1.5-inch lesion, because it was a lesion, is now a 4-millimeter radiolucency. And ultimately, the reason she came back was because now this tooth was bothering her, and you can see I did a root canal here as well. So I did these 2 root canals, and you can see the difference in what I took away here and here versus here. But the amazing thing here is I think everybody would have said, oh, you know what, just take out the tooth. And ultimately, I was able to save this tooth, and the girl is 17, and I would not want to lose this tooth if I can't even restore it with an implant, and you can't when you're 17. By the way, this is called a soffit, which is the amount of the tooth structure that you do not, you clean without removing here. There's a term for it, and that's called soffit. Okay? I'm going to show you a final case. In this case, I'm just going to show you because I want you to understand the value of cone beam. This is a healthy 18-year-old kid. The guy's in great shape, football player, has a six-pack, great bone. You think, oh my God, this guy's in such good health and shape. Look at the bone here. Fantastic, fantastic, fantastic. Not so fantastic. Okay, and you say, well, this is probably broken. You got a J-shaped lesion here, a J-shaped radiolucency, something here. But I always want to know more. I want to say, well, why is this failing? Because this looks pretty good, that looks good, this good, that's not good. So is this a post that's here, or did they miss a canal and not go all the way? Ultimately, it probably doesn't matter because this is J-shaped and it's broken. And I can probe here, so I know it's broken. And there's a lot of tooth structure. Maybe that's why it's broken. Never got a crown, right? Remember I just said that it's important to crown all posterior teeth? Well, here's the interesting thing. Most people would do what? You would just take it out, you put an implant. I would bet that even today, a lot of periodontists would not take a cone beam, or oral surgeons, or general dentists, or endodontists for that matter. Because great bone, great bone, great bone. You say, all right, I'll just graft it, stick my implant. Watch this. Here's a tooth, 4 canals, and yes, it was a canal that did not go all the way down. It was not a post. But here's the inferior alveolar, which comes down here, ends here in the mental foramen, but has 2 offshoots. One offshoot goes here, the other one starts to go here, and look where it goes. Right in the middle of the tooth, all the way straight up into the furcation. Why is that important? Well, obviously, if you're going to extract this tooth and do an implant, you're going to have problems because you're going to first say, huh, it's a little weird. I'm getting a little more bleeding than I would expect from a healthy 18-year-old kid. Then when a couple days later the kid says that he's having pain and paresthesia, you're going to say, well, that can't be. I know I didn't inject anywhere near the foramen. So, you know, something's wrong with you, kid. There's no way it can be me. And the truth is it can be you. And although I'll tell you that cone beam is not the standard of care for surgery, I can't imagine doing surgery without a cone beam for this particular reason. Okay? So remember, everything in life is perspective. And this is my favorite cartoon where this guy thinks he's rescued by the boat. He thinks he's rescued because he can finally stand up, stand on land. And really, they're both screwed. Okay? So hopefully, you know, what I went over today will help you. I'm going to move now to questions because we're running short on time. People were wondering what rotary system I use. I generally use TF. I sometimes finish with Brasseler sequence. I'll also use Pro Taper and Pro Taper Gold for retreatments. I use everything. You know, I treat every tooth individually. So depending on, you know, what that tooth is, and what it presents will determine how I do it. How I obturate is I use a cone, I put very light sealer on it, and I do either System B and hot tip, or I use a similar hot system from Kerr, which is a cordless unit that they have, which is basically like System B and Obtura, and it's cordless, so I like that. Let me see. Could you talk about single versus multiple visit? Yes. When I have a necrotic tooth, I will always do it in 2 visits. I think that you really want to do 2 visits on necrotic teeth because I like to medicate them with calcium hydroxide. There are people who don't, but I think that that's generally not a good thing to do. You're going to get more post-operative pain. Calcium hydroxide is antimicrobial, it's basic, and it does a great job of sticking around. It has good substantivity, so it will help you out, okay? So use it when you can. But otherwise, vital teeth, you do want to do it you know, in 1 visit. Someone talked about if you have extensive caries, do you advocate removing everything? Generally, the answer is yes. I may not remove an entire restoration normally, but if there is extensive decay and I'm worried, hey, you know what, there might be more decay under the restoration, then the answer is yes. And so generally, I will remove as much as I can. But other times I don't. And let's say I have MB2 failing, and everything else is fine, especially now with the cone beam, I can see there's only an area on the mesial. There are times where I may actually just treat that mesial canal, and I won't treat everything else like I did in the past. And I'll tell you that there's really only 1 time that I can remember that I got burned doing that, okay? Someone talked about apex locators not getting the reading. So yes, I did a whole article on that. If you look up, I think it was the Forametron, you will see that, and Joe Chikvashvili, apex locators. you should be able to see it. But I'll give you some quick tips, which is use a bigger file. Try to not have, you want it to be a little bit wet, the canal, but not in the chamber, or you won't get readings. A larger file, 25, will give you a better reading than a 10. Obviously stay away from any amalgams and things like that as you can. Okay? How long do I book a molar root canal? I usually book an hour. If I can't do it in that hour, then I'll just bring them back and I'll do it again. Are the C files still stiffer than the K? The answer is yes. So they are stiffer. So on crazy curves, I will try to use stiffer rather than, I'll use K files rather than the C files, which are stiffer. But sometimes you can even use the C files. Someone said, they can't get patency. If you can't get patency, then you're either blocked or you have a tough curve. So sometimes you will step down to a smaller file and try to get around the bends. But normally the number one reason you're not patent is curvature. I always tell people the answer is curve. Can it be debris? Of course it can be debris. But, if you irrigate enough, you should be okay, and you should be able to get through most blockages with the exception of type 2 canal anatomy. That is very challenging. So generally, it's a curve. Okay, so if you have a problem, try to pre-curve the file, try to figure out which way that curve is. What I do is I take a thinner file, a 6, 8, 10, and I can sort of see the way it bends as it gets down there. I'll also use a M4 handpiece by Kerr. I think it's a fantastic handpiece because it really will save your fingers. And I'll tell you that even though I don't really lecture for Kerr anymore, back in the days I used to, even before I did, I often told people you should buy the M4 handpiece because it's a reciprocating handpiece, similar to the Wave 1, but a little different because it goes 30 degrees back and forth, and it will save your fingers. Okay, so that's the M4 by Kerr. And you can put those files that I was talking about by Roydent on that handpiece, and it will just save your fingers and get you down there faster. Irrigation, I just use full strength bleach. I do use Endovac sometimes, particularly if I have draining pus, like I actually had 2 cases in the last week that I used Endovac on it. You can use it for everything. I think it's fantastic, but it does slow me down a little bit. And so although it's a fantastic system, negative pressure system, I don't use it unless I really have to. Do you think finishing an F1, F2 is too destructive? Conservative canal access preparations. So they're talking about the, pro taper. No, but the problem with the issue I have with the pro taper is that F1, F2 have big tapers and they keep the tips really small. And a lot of times I think you really have to open it up a little bit bigger to really get in there and clean everything out that you need to clean. So ultimately, people always say, well, what do you want to clean to? Well, that comes with experience. You have to do enough teeth where you know whether this tooth is likely a 20 or a 40 or a 60. I had a tooth today that was 100. It was completely open apex because she had trauma and the tooth had not been treated for 20, 30 years. And ultimately, it involves 3 teeth. The oral surgeon is going to cut all those teeth, and 2 of them I was able to get perfect to length, and 1 I was 3 millimeters long. I don't think I've been 3 millimeters long on a tooth in literally 3 years, but there's nothing you can do when it's huge. And what you can do is you can fill it with MTA and use collagen membrane and so forth, but in this case I didn't really have to worry about it because it was going to be surgically cut. Okay? So anyway, I'm still getting questions, which is great. So hopefully I think this was very helpful for you guys. And I appreciate everybody's questions and participation. But this, unfortunately, is now the end of the presentation. We're running out of time. We got about a minute left. So I just want to remind you there'll be a little quick 5-question quiz so that you can get your CE credits. But I really hope that today's presentation was informative. It was definitely different than even what we did a week ago, so hopefully there were some more tidbits that I helped you guys with. I'm always happy to help. My email is njrootcanals, NJ like New Jersey, rootcanals spelled out with a plural S, @gmail.com. If any of you ever have any questions, I'll always be happy to answer them, and I really hope you get some information from, some valuable tips from what we did today. So thank you all for joining us. We have people from all around the world, literally. I appreciate your time, and I hope you all have a great evening or a great morning wherever you are. Thank you again, and have a great day. Bye-bye.